We're going to get into some of the diagnosis components. Okay, this is a real echo report that a patient came to me with. I said to this patient, you need an echocardiogram. And they said, doc, don't worry about it. I just got an echo a couple of weeks ago. Let me get you the report. And this was the report. And I posted this on Twitter. And if anyone knows Mark Tuttle, he's an interventional cardiologist in Virginia, and I've never met him, but I posted this on Twitter, and he had the best response. Not all echoes are created equally, right? We've talked a lot about EKG, and these detections, but there's this whole next step, which is, okay, I got the patient to the echo, but did the echo actually get interpreted correctly? Was the echo of high quality? And we struggled with this just at NYP. We are 8 hospitals, 6 echo labs. I can't even imagine how many people, we've probably got 300 different people reading echo. So we deal with a lot of variance in quality, a lot of concerns around this and the like. So this is some phenomenal work from Tim Poderuca, my best friend, my co-creator, who's at the Mayo Clinic now, and Aaron Long, one of our lead data scientists. This was our work that came out in Circulation last year. So I think the single hardest task we ask of clinicians for interpreting echocardiograms is regurgitation. And I think mitral regurgitation is amongst the most challenging. And the reason for that is just such huge variance in interpretation standards. And you can do PISA, you can do qualitative assessment, you can do whatever you want, but it's just a really squirrely and really difficult task. And so we asked ourselves, can an AI model do it at the quality of an academic lab? So we trained this model at Columbia, we tested it at Weill Cornell's lab, and what we saw was 96% agreement between the AI model and the human expert. And then the 4% of the time there was disagreement, half of that the AI model was right, and the human expert was wrong. And then we just had a paper come out today in EHJ where what we looked at was MR, AR, and TR. And then we also looked at the ability to predict the risk of progression. And what we saw was the AI model could take someone who had mild MR and put them in a high-risk category and show that there was a significantly increased likelihood that that person who is AI high risk with mild disease was going to progress to moderate or greater disease than someone who was in the low-risk category and only had, mild to moderate or moderate disease and the like. So these tools are coming, and what we can see is these AI models are already functioning at a level where they can help read at an academic lab quality. And basically where we're going is every single echo can have a second person interpreting it. So what we've done just in the last month is we've actually turned this on in our echo lab, where at the end of the week, the AI model reads all of the echoes, and we look at the echo reports, and any place where there is a significant discrepancy between the original read and the AI model, we do blinded adjudication on those echoes. So today is March 29th. In 3 days, we're going to have the first case. So 3 months ago, we had the first case of an opportunistically screened case of aortic stenosis caught by ECG that led to a TAVR. We had the EchoNext model on, and we saw a patient who was on the orthopedic surgery service at Brooklyn Methodist. We said, hey, I think you should get an echo before that patient goes to the OR for their broken hip. They got an echo. She had severe AS and a reduced ejection fraction. She got a TAVR that same week and a hip replacement that same week, and she is home recovering really well. On Tuesday of this week, the first case of AI discovered severe mitral regurgitation from echocardiogram is going for a mitral valve replacement with one of our cardiac surgeons, where the original interpretation was moderate MR. The AI model said it was significantly more than that. We adjudicated it and we said, hey, this person needs to come back in. I called the surgeon and I said, hey, we got it wrong. We're bringing this patient back in for a transesophageal echocardiogram. She had torrential MR, and she needed a mitral valve replacement. And this is a 62-year-old woman who is otherwise healthy. Her EF was already borderline, right? For her to go 2 or 3 years, like the guidelines recommend and what the real world has happened, before she gets her next echocardiogram for that moderate MR, could have been catastrophic for her. So, what we're seeing is there are all of these downstream pieces that have to also come together, right? You can get the patient from ECG to echo, but then is the echo going to be read in the right way? Can you have scalable impact? Can you create an academic lab interpretation anywhere And can you help find those gaps? Can you have basically a second echo read for every single study? Cardiac amyloidosis, which is a relatively rare cause of heart failure that we're realizing isn't that rare, is something very near and dear to us at NYP. My mentor, Matt Maurer, was one of the co-creators of the pyrophosphate scan, which is one of the ways we diagnose the disease. He wrote the first New England Journal paper on tafamidis, the first treatment to show mortality benefit for patients with cardiac amyloidosis. So we built an AI model that looks at ECG and echocardiogram, and it turns out that it can give us a high degree of probability that the patient has undiagnosed cardiac amyloidosis. And Matt said something, Matt's a bit of a spitfire if anyone's met him. He said something funny to me. He's like, I know that this disease should have a preponderance in Blacks and Caribbean Hispanics, and my clinic is like all white people from Jersey and upstate New York. Like, what's going on? I thought, well, that's interesting. Let me take a look at it for you. So, about 46% of the people who engage in care at Columbia are white. About 43% who get an EKG are white. Echo, slightly more expensive test, 52% are white. PYP scan, 80% white. The people we send for advanced diagnostic testing are twice as white as the general population we care for. There are inherent biases that exist not because of anyone's malfeasance in clinical care today. So everyone, I think, is rightfully worried about AI creating bias, but I think when used correctly, AI can actually fix some of the biases that exist in healthcare today. So the AI model, looking at this same population of high-risk patients, would actually have that go from 80% to 54% white. So we decided we want to put our money where our mouth is. And so we've been running a 100-patient clinical trial finding undiagnosed cardiac amyloid. I shouldn't be telling you guys any of this stuff, but I just don't care because I think it's really interesting. So what is our baseline rate of positivity? We're one of the busiest cardiac amyloid centers in the world. So in 2023, we sent 830 people for the scan, 117 were positive, 14%. In 2024, our rate of positivity was around 12.5%. So we're a very busy center, and about our positive predictive value in routine clinical care is 12.5%. What about in our trial? Our trial is sitting at 42% positive predictive value. None of these patients were otherwise being evaluated for cardiac amyloid. The AI model is finding people who are otherwise missed in our health system with a positive predictive value 4 times routine clinical care. It's led to a 24% increase in total number of diagnoses in our health system. The AI model is flagging people as positive for cardiac amyloid 384 days on average before they got into the scanner as part of the trial. All of these patients have been started on treatment. And because it's a clinical trial, for every 1 patient who I thought was a good candidate that I could get into the scanner, there were 4 more I couldn't get into the scanner because the clinician didn't respond or the patient didn't want to be a part of research. I could have easily doubled the number of cardiac amyloid diagnoses made at one of the country's busiest cardiac amyloid centers with this. We did not think this was going to work. I do not think all of the technologies we build was going to work. I am still in awe of this, that the technology is working at this degree of efficacy. And so this is one of the key things that we're now trying to roll out in many centers around the country. Because for those who don't know about cardiac amyloid, these people need totally different medications than other people with heart failure. If they don't get those medications, they die, period. So they get missed and then they die from their disease because we can't help them. And traditional treatments for heart failure do not help them. You have to diagnose these people, and you have to diagnose them at a very specific time in their disease course if you're going to make any difference. Does anyone here read The Wheel of Time? No. Great set of books. The author unfortunately passed away from cardiac amyloidosis. Okay, so we talked a little bit about Echo Next. I'm proud to announce the Cactus trial. So we are doing a 6,000 patient clinical trial in 8 emergency departments over the next 12 months. First, we notify the clinician taking care of the patient, and then if that clinician ignores the alert, it comes to our care management team, and then we determine whether or not we should get an echo on the patient. So this is the largest cardiovascular AI trial in the United States to date. It's also really the first test of a cardiac AI safety net, and that's what I'm excited about. We're basically treating this like an abnormal troponin level not being acted upon and saying this patient needs to be acted upon. We have a full dashboard that's integrated inside of Epic. I'd already told you we've already had our first case of a TAVR being done from opportunistically screened aortic stenosis. I just want to leave you with that slide about the 2 key hypothesis. I ordered more echocardiograms than any other clinical provider at New York Presbyterian in the last 3 months. I had a higher rate of positivity for new diagnosis of disease than any other of the 5,000 providers at New York Presbyterian in the last 3 months. I never met any of the patients. That should make, people in the room feel uncomfortable. It is a new way for me to practice cardiology, but the number of people that I've been able to help is significantly increased for it. There are a lot of thank you letters that are hung up in my office. And so for me, it's worth reimagining the work. Thank you.